Okay, good morning or good afternoon or good evening depending on where you are in the world. My name's Helen Walden. I'm the Managing Director of Sound Therapy International, and it's very grateful for everyone here to be here today to listen to our webinar, the Supporting Research for Sound Therapy, and thank you very much for making the time available. And I'll be just introducing everyone in a minute. I just would like, before we begin, for those people, and this presentation is for sound therapy consultants only, and as members of our sound therapy consultant team, we have access to specific resources, including these webinar education system seminars. And thanks for your time. So a little bit of housekeeping first. And that is, of course, we're in presentation mode only. Sometimes it gets a bit hard with the feedback if we have all the lines open. So we will be running for about 60 minutes, 45 minutes presentation and some question time. We'll see how that works. And this time you should all be able to, if you do have a question, we would love to get your questions. Please type them in the questions box on your screen on the right-hand side. If we'll get to what we can today. Any questions that we can't get to, then of course we'll respond by email to everybody tomorrow, anyone who's in attendance. Now, for those of you who may be having any technical difficulties, can't hear or see, if you want to email Anton at esals@soundtherapyinternational.com, or you can Skype on sound.therapy, or just call our office. We'll certainly get you on the call and make it happening as soon as we can. So anyway, what I'd like to do now is just introduce the presenter, which of course is the founder and director of Sound Therapy International, Raphael Joudry, who is Master of Psychology and Bachelor of Social Work, and has been with this company for 23 years now, I think, isn't it, Raphael?
Yes, that's right.
And
there we go. I was trying to get the next slide on.
So Raphael's flying solo on the controls today, and I'm sure she'll do very well. So I'm going to hand over to you now, Raphael, to get us all started. And thanks, looks like we've got quite a few people coming. We've got a few more we're expecting, but to respect the people that are here on time, we would certainly like to get going now. So, okay, over to you, Raphael. Thank you.
Thank you very much, Helen. So just to give you a quick overview, this presentation today will cover how sound therapy impacts the auditory system, the latest discoveries in tinnitus retraining therapy, confirmation of Tinnitus's theories by Stephen Porges, and Richard Davidson's work on the left brain. So some very interesting topics there. The theory behind sound therapy is that the ear is an active organ whose role is to stimulate and enhance brain pathways. Tiny muscles in the middle ear respond to certain types of sound stimulation, making the whole auditory system into a dynamic, revitalizing tool for the brain. Now, special filtering algorithms or patterns and high-frequency filters are used to enhance classical music so that it becomes an intensive, progressive therapy program. Originally developed by the ear specialist, Dr. Tinnitus, in conjunction with the Sorbonne University in Paris, the discoveries behind sound therapy are now being confirmed by new neurophysiological research from America. Stephen Porges, the director of the Brain Body Center at the University of Illinois at Chicago, has developed Polyvagal theory, which explains how the vagus nerve acts through the autonomic nervous system to control our social emotional processes. According to Dr. Porges, many children with developmental difficulties are in a state of high anxiety, and as a result it is difficult for them to attend to the high-frequency sounds such as human speech. Richard Davidson, director of the Laboratory for Affective Neuroscience at the University of Wisconsin in Madison, has determined that stimulation of the left brain cortex is responsible for many of the benefits of meditation. Sound therapy replicates this left brain stimulation and achieves similar results. Now I'd like to look at a model here that was developed by Dr. George Richards, speaking at the Australian Audiological Conference in 2004, and he described a process of a breakdown in the auditory feedback loop. He states, through overstimulation, sickness and disease, drug therapies and other oxidative stress, the integrity of the afferent and efferent nervous systems is compromised, with loss of muscle tone and synchrony in the synaptic firing order. This compromise manifests itself in myriad of symptomatic maladies such as hearing loss, tinnitus, loss of balance and coordination, loss of attention, inability to hear and understand in the presence of background noise, fatigue, tiredness, headaches, anxiety, depression, and on and on. Always keep in mind that the ear-brain system supplies 85% of the ongoing cortical energy. So when damage occurs to this delicate feedback system, the homeostasis of the entire organism is compromised. Let's take a look at brain plasticity. A new understanding of the interactions between the ear and the brain has emerged as a result of the last few decades of research on brain plasticity. The Canadian psychologist Donald Hebb in 1949 proposed that memories are stored in the brain in the form of networks of neurons that he called cell assemblies. He surmised that through experience, i.e. learning, when presynaptic and postsynaptic neurons fire action potentials together, the strength of the synaptic connections between them is enhanced. And as a result, synaptic associations would grow stronger and tend to persist. So in other words, cells that fire together wire together. Decades of research have now...
I'm glad you clarified that. That was getting a bit heavy for me.
Sorry, Helen.
Fire together, wire together.
Yes,
Thank
it's
you.
good, isn't it? Now, decades of research have now confirmed this theory and proven that substantial changes occur, not just in the memory centres, but also in the sensory processing areas. So the now accepted theory of neuroplasticity, as summarised by Norman Doidge in his excellent book, The Brain That Changes Itself.
I hope you've all read it. It's very good.
Yes, definitely recommended. This theory holds that thinking, learning and response to sensory stimuli actually change both the brain's physical structure and physiological function. Evidence suggests that auditory remapping can improve listening and comprehension, that enhancing central auditory processing improves sound differentiation in noisy environments, that a potential exists for improved listening for those with hearing loss, that high-frequency sound stimulation enhances cortical sound processing, and that regular rhythmic activation of the ear muscles assists to normalise their function. So I'll be covering some of those points today in more detail. Here's a wonderful artwork which I think illustrates
one of
the
those
point.
at school.
Now don't be rude. Research has
It wasn't
shown...
that organised.
I see. So I'm using this to illustrate this point. Research has shown that by providing the right input in a frequent, intense manner for a long enough period of time, firing patterns in the brain become more organised and efficient. This added stimulation helps the auditory pathway to process sound in a more normal fashion. Sound signal reception is changed in the auditory cortex so that the brain can finally make sense of the signals it receives. Richards expanded thus on Tinnitus theories of muscle function and cortical charge. Richards said, through highly organised temporal stimuli, i.e. classical music, which has undergone high bandpass filtration, meaning the sound therapy process, a restoration of aural, that's ear, muscle tone and synaptic firing order occurs. Now when these two things happen, an enhancement of mechanical tone and tuning occur to provide better cortical processing. Better cortical processing corrects a myriad of problems ranging from anxiety relief, better hearing, tinnitus control, better balance and coordination, to feelings of happiness and well-being, thus promoting a better homeostasis of global proportions within the individual. So it seems that it is the re-establishing of the ability to listen to the higher frequency that is responsible for repairing and reorganising cortical pathways. The energy levels coming in from the high frequency areas are more intense than for the lower frequencies.
And that was Richards in 2004.
Richards, yes, speaking at the Australian Audiological Conference. Yes. So I'd like to talk now a little bit about tensor tympani syndrome. Now this is a just newly identified condition by a researcher called Ramirez, who has stressed the importance of interdisciplinary diagnosis to achieve clinical success in relation to ear muscular disturbance. And he states, tensor tympani muscle physiology and function in the middle ear have been veiled, but adds, the tensor tympani muscle, in spite of common belief, is not an inoperative muscle. We know this due to it responding electromyographically to strong sounds and vocalization, chewing, swallowing, and facial muscle external stimulation. The tensor tympani muscle's normal activity is related to a reflex neurological mechanism known as centrifuge auditory inhibition control.
What?
CAIC, that'll do it. This works in sound, sorry, I'll say that again. No, it's there on the screen. Centrifuge auditory inhibition control. This works in sound trauma protection and hearing discrimination of low tones, besides complex co-activation during velopharyngeal, that's soft palate and pharynx movement, so it has a role in the movement of the soft palate as well. When tense, the action of the tensor tympani muscle is to pull the malleus, the hammer bone, sideways, tensing the eardrum, damping vibration in the ear ossicles, the little bones, and thereby reducing the amplitude, loudness of sounds. This muscle is contracted primarily to dampen the noise produced by chewing, compared to the more general dampening function of the stapedius, the stirrup muscle. What Ramirez has identified is that abnormal spontaneous action of the tensor tympani muscle is due to increased reactivity, excess tension or spasms, and this has been dubbed by Klokov as tensor tympani syndrome. And he says this can lead to some unusual and hard to diagnose hearing disorders. The tensor muscle activity does not cause hearing loss in the conventional sense. Still, the patient may complain of difficulties catching what people say. And he mentions associated symptoms. This is Klokov. The associated symptoms he has observed are fullness, pain in the ear, 83%, tinnitus, 62%, distorted hearing, 42%, tension headaches, 88%, vertigo or dizziness, 80%.
And that's with the tensor tympani syndrome.
That's right. These are the associated symptoms to tensor tympani syndrome, spasm in the tensor tympani muscle. Jonathan Hazel, similarly stated, we estimate that over 40% of our patients at the Tinnitus and Hyperacusis Centre in London complain of or remark on symptoms relating to the tensor tympani muscle. Routinely suggested therapies for this include muscular relaxation, sedation, counselling and TMJ, temporomandibular joint realignment. More precisely and therapeutically permanent is the re-education of the middle ear muscles postulated by Tinnitus and delivered by sound therapy. As well as better hearing, listeners report relief for hyperacusis as the normal responsiveness is restored to the middle ear muscles.
And that's been your experience?
That's the experience we've observed over 20 plus years with sound therapy, and we can now explain it with this theory of tensor tympani muscle, which has been identified by these researchers. So I'd like to just talk about tinnitus retraining therapy and some of the changes in tinnitus retraining therapy. Jastrogoff described the neurophysiological model of tinnitus in 1991, and Jonathan Hazel began treating patients with tinnitus retraining therapy in his clinic in London at around the same time. Over the ensuing 20 years, tinnitus retraining therapy, TRT, has gradually become one of the more widely used and certainly the most widely discussed modalities in the management of tinnitus and hyperacusis and related conditions around the world. In addition, many hearing healthcare professionals who choose not to formally include TRT in their clinical practices have found it helpful to utilise some of the principles of TRT in their recommendations for sound therapy and in counselling of their patients. TRT has been refined over the years in Baltimore, Atlanta and in London, and it undergoes continuous modifications aimed at shortening the duration and enhancing its effectiveness. Today I will outline some of the significant changes in TRT as described by Stephen Nagler at the ADA conference in Florida in 2011. The purpose of this discussion is to see what we can learn from these changes that relates to sound therapy.
And some of the doctors on the call today will be there, remember us, at the ADA conference in Florida last year.
Yes, we attended that conference. So this was a very interesting presentation by Stephen Nagler, and what he covered concerning TRT is that quicker results are now being claimed with TRT, and this is thought to be due to the following 4 factors. 1, volume of sound generators set lower than previously. 2, identifying misophonia. 3, education about autonomic response in tinnitus. And 4, early follow-up. So I'm just going to go into a little bit of background on these 4 points. 1, now setting sound lower than previously, but not lower than 6 decibels. The protocol states the devices should be set, this is for TRT, the devices should be set as loud as possible as long as the sound is not annoying, does not interfere with communication, and is at or lower than the mixing point, meaning the point at which it starts to blend with the tinnitus. This refers to sounds used primarily for distraction and masking, rather than music for oral rehabilitation, so is not necessarily directly applicable to sound therapy. 2, Dr. Jastreboff believes that misophonia has in the past been seriously underdiagnosed.
What's misophonia?
Misophonia is defined as abnormally strong reactions of the autonomic and limbic system to sounds resulting from enhanced connections between the auditory and limbic systems, but not involving hyperacusis, which is a significant over-amplification within the auditory system. So a lay example would be fear and emotional distress caused by sound. That's what is meant by misophonia.
So when my ex-husband blew a horn in my ear and I fell flat on my face in shock.
That was a traumatic sound event. If you ever afterwards had a strong emotional reaction to the blowing of a horn,
next time I hear a horn,
that would be misophonia.
Right.
Yes. So Jastreboff feels that it is extremely important to look carefully for misophonia in each patient and to address misophonia effectively when identified. He notes that the diagnosis can be challenging when hyperacusis and misophonia coexist, which is often the case. Misophonia is present, almost by definition, in all patients with clinically significant hyperacusis, but the converse is not true. Once misophonia is identified, Jastreboff offers 3 treatment protocols for consideration, and the difference among them lies in the extent of control given to the patient, but common to each is the creation of a positive association between 2 things. 1, the sound or sounds that do not appeal to the patient, and 2, an activity, for instance, listening to the music, going shopping in a mall or eating out, that the patient finds pleasant. So they're associating an unpleasant sound with a pleasant activity in order to overcome the misophonia. So point number 3, Jastreboff has revised some of his counselling strategies for the purpose of addressing what he feels are previously underappreciated conditioned reflexes involving the conscious upper loop pathways and the subconscious lower loop pathways in the neurophysiological model. Specifically, he notes that traditional TRT counselling effectively addresses the upper loop but cannot fully address the lower loop because the autonomic response itself serves to reinforce the conditioned response in the lower loop, which is why habituation of reaction can require considerable time even after the patient has fully absorbed and understood the model on a conscious level. So what I understand him to be saying is consciously the counselling is working well, but how can we make it more effective at the unconscious level?
Subconscious level.
Yes, subconscious level. Resonance is a well-established phenomenon in neuroscience and is described as the enhanced detection of weak signals, paradoxically resulting from mixing the signal with low-level noise. Now, the manual of notes distributed to those attending the 26th course on tinnitus retraining therapy for the management of tinnitus and hyperacusis in 2010, that's the reference, sorry, for that point. Jastreboff makes a concerted effort to explain this phenomenon to each patient on a level that the patient can appreciate. So he explains the role of the autonomic response as a source of reinforcement that inhibits the passive extinction of tinnitus. So how the unconscious response is preventing us from healing the tinnitus. In sound therapy, we go a step further, including autogenics training in the tinnitus program, where the autonomic nervous system is gradually calmed and brought under conscious control through repeated training. So this is a very important aspect of tinnitus management in sound therapy. Dr. Jastreboff, point number 4, early follow-up, Jastreboff feels that initially not enough attention was given to early follow-up. The primary function of the first few follow-up sessions is to clarify any points of confusion and to reinforce the model through continued counselling. Follow-up sessions, ideally in person but by phone if necessary, are strongly recommended at 1, 3 and 6 months, with the 1 month and 3 month sessions being the most important. And a similar protocol is being recommended for sound therapy synergy. So having covered the points on TRT, I'd now like to talk a little more about middle ear muscle function and dysfunction. This is an area of particular interest of mine. It's a fascinating and innovative area, first described in the writings of Dr. Tinnitus. Previously, this was a matter of conjecture and anecdotal observation by sound therapists. However, now Dr. Stephen Porges' research seems to support Tinnitus's theory on middle ear muscle dysfunction. Stephen Porges, a professor of human development at the University of Maryland, may be closing in on the reason why auditory retraining with sound therapy may be beneficial to children with autism and other related disorders. Similar to the work of Dr. Tinnitus, Dr. Porges' research has focused on the 2 muscles in the middle ear, the tensor tympani and the stapedius. Porges has found that the same nerves that control these 2 muscles also control vocalization, facial expression, heart rate and breathing. Now, when we experience fear and or anxiety, the 2 muscles in the middle ear can no longer diminish low-frequency sounds. Diminish.
Oh,
they can no longer diminish low-frequency sounds. Based on an evolutionary perspective, this would allow the individual to attend to all sounds in his or her environment in order to perceive danger, rather than attending mostly to high-frequency sounds such as speech. According to Porges, many children with developmental disabilities are in a state of high anxiety. As a result, it is difficult for them to attend to only the high-frequency sounds, such as human speech. Porges has developed an intervention that is similar to the Tinnitus method. After being encouraged to relax and do relaxing activities, the child then listens to specific sounds or music within a narrow frequency range similar to the range of human speech. Gradually, the frequency range is widened, which is intended to vigorously exercise the 2 muscles in the middle ear. So this is just a picture to graphically illustrate that point that I found, but you can visualize and you can imagine the impact when you gradually widen the frequency range, that would be extending and asking more of those muscles in the middle ear. And so this is what is attempted with programs such as our Porges program and, of course, Dr. Tinnitus's program and our sound therapy program. Since the middle ear muscles share the same neural connection with facial expression and vocalization, Dr. Porges expects to see an improvement in communication as a result of an improvement in middle ear function. His 10 years of research on this subject has supported this hypothesis. Dr. Porges' line of research is very exciting and may lead to better understanding of some of the Tinnitus sound therapy effects. However, it does not seem to explain changes in many other areas such as handwriting and drawing, variety in diet, balance and coordination, sensory processing, vision skills and sleep patterns, which have been observed through the tinnitus-based therapies. Some of these changes may result from stimulation of the cerebellar-vestibular system, as explained in my book, Why Aren't I Learning? The line of investigation taken by Porges is based on polyvagal theory, a theory derived from over 30 years of research on the relation between the neural regulation of the autonomic nervous system and social emotional processes. The polyvagal theory explains how the structural and functional organisation of the autonomic nervous system has changed during evolution. The theory emphasises that during various states of challenge, the control of autonomic function shifts from the phylogenetically newer systems to the older systems. The theory owes its name to the vagus, a large cranial nerve that exits the brainstem and communicates with many of our visceral organs. The theory emphasises that there are two functionally distinct and phylogenetically determined vagal systems, an older system innervating our gut and a newer system controlling our heart and bronchi that is linked to the neural regulation of the muscles of the head. The polyvagal theory provides 3 points that led Porges to use acoustic stimulation in their protocol to improve social behaviour and communication skills. So this is the question, why did he choose to use sound to regulate these functions? Okay, first, the area of the brainstem that regulates the heart, i.e. the new vagus, also regulates the muscles of the head, including those of the face, middle ear, mouth, larynx and pharynx. When they studied the general function of these muscles, they realised that collectively these muscles provide an integrated social engagement system that controls looking, listening, vocalising and facial gesturing.
Oh.
Porges says,
I was just going to say, it's not showing the slide up yet, but
there it comes, the social engagement system.
yes. Maybe if you have too many facelifts, do you look like that? And you can't engage?
Probably.
Sure.
Or if your polyvagal system is not functioning correctly.
Right. I don't
Porges,
think is.
No, I don't think so. Now, Porges says, in fact, if the neural regulation of this group of muscles were dysfunctional, we would observe a face that did not work in social settings. Interestingly, these facial features reflect common behavioural symptoms that have been used to describe several psychopathologies, e.g. autism, depression, aggressive disorders and post-traumatic stress disorders, or emotional states during severe challenge, i.e. grief, rage, anger, loneliness, or medical illness, e.g. senility, AIDS or fever. So that's the first point. Second, the middle ear muscles play an important role in extracting the human voice from our complex acoustic environment. When the neural tone to the middle ear muscles is low, the middle ear structures do not actively filter out the low-frequency sounds that dominate the acoustic environment of our modern industrial world and do not amplify the frequencies associated with the human voice. That's a quote from Porges. So you see that is clear confirmation of what we've been saying with the tinnitus method about the importance of the role of the middle ear muscles in group conversation and sound differentiation in noisy environments. The neural regulation of the middle ear muscles is linked to the neural regulation of the other muscles of the face, which control facial expression and vocal intonation. Thus, stimulation, improving neural regulation of the middle ear muscles should integrate and stimulate the neural regulation of facial expression, looking, listening and vocalizing. So this is where it all ties together. The theory states that there is a degrading of the function of the social engagement system when the individual perceives the environment as dangerous. Conversely, if the individual perceives the environment as safe, there is the neurophysiological possibility that the cortex could regulate the lower motor neurons of the social engagement system to promote communication and social behaviour. Thus, the perception of safety was the primary requirement for Porges' intervention. In fact, he first called the intervention project making the world safe for our children. Borges' approach was theoretically designed to recruit specifically the cortical regulation of the social engagement system to promote the voluntary pro-social behaviours that are missing in autistic children. Thus, the intervention is seen as stimulation and exercise of a cortico-bulbar neural system, i.e. nerves that connect the cortex to the brainstem, that regulates the muscles of the head. So the intervention, wow. Yes, fascinating, isn't it?
Take a deep breath.
Hard to get your head around, but it's very exciting because it is now current, up-to-the-minute research explaining neurophysiologically what we are achieving with sound therapy.
That book, Polyvagal Theory, is a great book, but very tough reading. You've simplified that a lot, I know.
Well, I don't know if I have, but I've tried to summarise some key points of the theory pertaining specifically to the middle ear muscles. Mm-hmm. So the intervention is based on two primary principles. One, cortical control of listening and the other components of the social engagement system via the corticobulbar pathways requires the environment to be perceived as safe. And two, exposure to acoustic stimulation within the frequency band of human voice is capable of stimulating and exercising the neural regulation of the middle ear muscles and other components of the social engagement system. Thus, the intervention attempts to engage the active cortical control of the middle ear muscles as a portal to the social engagement system. So I hope that makes sense to you. It's bringing it all down to that very interesting interconnection, that the active cortical control of the middle ear muscles is a portal to the social engagement system. So we could say improving middle ear muscle function helps us to relate better to others.
Look, you've got a whole new application for sound therapy. I don't think that's what we're really talking about here, but who knows?
Communication, enhancing communication. That's what we're all about.
Doing more than communication.
Like Borges' protocol, did you think that was speed dating? Could be very useful. Wear your sound therapy when you go speed dating. So, like Borges' protocol, sound therapy aims to enhance the ability to extract the human voice in social settings via the cortical neural regulation of the middle ear muscles. Now, the filtering process we use is part of a complex algorithm that modulates the intensity of various frequencies to exercise and stimulate the neural regulation of the middle ear muscles and serves to integrate the components of the social engagement system. And that's where our system is similar, very similar to the process that Borges has been using in his research. I'd like to move on now to another body of research which is very pertinent to what we're doing, which has been put together by Richard Davidson using PET and MRI, positron emission tomography and magnetic resonance imaging. Davidson investigated connections between the prefrontal cortex and the amygdala. As I'm sure most of you are aware, the prefrontal cortex is the cognitive, conscious part of the brain, and the amygdala is the seat of negative emotions and instinctual responses. It is the site of anger, fear, and fight or flight reactions. Davidson was able to show that there are extensive reciprocal connections between the amygdala and the prefrontal cortex. First, he was also able to show that afferents, or signals coming from the prefrontal cortex, provide an important inhibitory input to the amygdala, meaning we have the option through activation of the prefrontal cortex to consciously control our negative reactions. Second, it was demonstrated in rats that lesions of the medial prefrontal cortex dramatically prolong the maintenance of a conditioned aversive response. In other words, animals with medial prefrontal damage retain aversive associations for a much longer duration of time than normal animals. Of particular interest in relation to sound therapy is Davidson's work on asymmetry.
That's in there, isn't it?
That is Richard Davidson doing his research, yes. Davidson noted that left side, left prefrontal activation appears to facilitate two processes simultaneously. One, it maintains representations of behavioural reinforcement contingencies in working memory. 2, so it enhances memory basically. 2, it inhibits the amygdala. In this way, the time course of negative affect is shortened. In other words, negative feelings don't last as long, whereas the time course of positive affect, positive feelings, is accentuated. So it enhances our positive emotional states, if you like. That is, he achieved that through activation of the left prefrontal cortex. He also found that glucose metabolism in the left medial and lateral prefrontal cortex is strongly associated reciprocally with glucose metabolic rate in the amygdala. Thus, subjects with greater left-sided prefrontal metabolism have lower metabolic activity in their amygdala. So if the left prefrontal cortex is working better, there's going to be less trouble from the amygdala.
What a relief.
Yeah, isn't that great? Simple. These findings imply that prefrontal cortex plays an important role in modulating activity in the amygdala. At the same time, the left prefrontal cortex is also likely to play a role in the maintenance of reinforcement-related behavioural approach. So perhaps the dampening of negative affect, the shortening of its time course, facilitates the maintenance of approach-related positive affect. So positive emotions are stimulated where the amygdala responses can be dampened. So what do I mean by all this, and how does this relate to sound therapy?
What a good question. I was going to ask you that myself.
Were you? Yeah. Maybe a few people. So let me answer that question and let me try to make it very clear. What this means, in short, is that sound therapy, by specifically targeting centres in the left prefrontal cortex via increased right ear stimulation, has the potential to increase positive moods, a positive outlook, and the reduction of stress and anxiety, as has been reported by many thousands of listeners over many decades.
Mm-hmm.
So that concludes the presentation. There's my references.
Lots of references.
Thank you very much.
Wow, thank you, Raphael. That's been huge. So much you've covered so much ground there. I think it would be would take quite a while for it all to sit in, but I'm sure you can listen to it again and go back in. If those people who missed parts of it can go back and revisit the material. I mean, I know I've had to look at some of this a couple of times to get it in my thick scone. So, but I'm sure you have some questions anyway, and so I'll just ask. I've got a couple of questions here. I'm just trying to scroll down this tiny little window in here. Yes, it is being recorded, and you have access through it through our sound therapy synergy website.
There will be access in the future.
Yeah.
I'm not sure if it's available just yet.
Yep. Yep. Oh, please, and can you please spell Dr. Steve Porges' last name, please?
Porges. P for Peter, O-R, G for George, E-S.
Mm-hmm.
Porges.
And here's another one. What is the best reference for Stephen Porges?
Okay, look, for the lay reader, I would recommend his book, Polyvagal Theory, Polyvagal, V-A-G-A-L. A fascinating read, a little bit heavy going, especially in the early chapters, so feel free to browse around, but that's probably the best place to look to get an overview of his work.
Okay, and another one, Raphael, does work with sound therapy impact on other senses besides hearing?
Yes. Well, there has been fascinating work on multisensory processing